So this is the last session of, it started in 2004, so this is 2014. You can't hear me. I suggest, Bob, you do something about it. Any rate, so we're glad that you're here, and there are roughly each time there are between 200 and 300 people who are out there on the NIH campus who are watching on their desktops. So when you, and we welcome you, I'm sure the speakers do, to ask questions, either wait a minute until we get a microphone to you or speak very loudly, or maybe the speakers will repeat the question, because I keep getting emails saying, what were they answering? It's sort of hard if you know the answer, but you don't know the question. At any rate, so some of you have not been here before, but I just take a minute to point out what this structure is, and I assume that everyone in the room knows that it's the most famous bridge in the world, right? That's the Brooklyn Bridge. And why do we put that up there? Well, for three reasons. One, because the picture was taken by my grandfather. Second, because it represents symbolically what we're trying to do, which is to bridge the major advances and problems in sort of basic biological, mechanical, mathematical science with major health problems. And that's been the topic of every session that we've ever had. Now, this is 1883. Those two gentlemen standing out there are undoubtedly surgeons. And what they're talking about is, what are we going to do about cancer? Because all we had was surgery back in that time. And one of them saying to the other, if we could only pick it up when it's early, we can surely cut it out. And of course, this is sheer speculation on my part, but from that point on, the concept arose that early diagnosis meant better outcome, and the only thing available, of course, in those early days was largely surgical. And then we come into the post-genomic era where the whole paradigm shifts, and it's a question of this premise that an early diagnosis, then the question is, what's an early diagnosis and what are you diagnosing? And that's where we are now. So it's the area of search for risk factors, largely genomic, also environmental, of course, and so-called cancer markers. And the premise is, like before, that early detection will permit more effective treatment, drugs or surgery. In some cases, it even, as in the case of BRCA mutations, has led to prophylactic surgery before there is any tumor at all. So this is the enormous spectrum that's changed from the end of the 19th century. So today's topic is really is this premise correct that was on the previous slide? The biology, the course of different cancers varies. What are the statistical chances of having a cancer given these different risk factors? And very importantly, what do the markers mark? What do they have to do with the biology of the tumor? And of course, whether action on the premise that this is early diagnosis sometimes can do more harm than good. And that's really the subject of the broad picture. And so we're going to begin with Barry Kramer, who is director of the Division of Cancer Prevention in the NCI. We've posted several of his most recent papers on the website, and I encourage you to read them because they, as you'll see from his talk, they prompt a lot of thinking that maybe you wouldn't normally think of if your life was directed to a very specific, let's say, reductionist research problem rather than a more broadly clinical or even global kind of problem. So Barry trained in medicine at Washington University of St. Louis and has been here at the NIH in various capacities, all related one way or another to this matter of cancer detection and cancer prevention. He's extremely well known for the excellence of his writing, which he'll communicate to us today, and for the provocative questions that he raises. So, Barry, it's a pleasure to have you with us.
Oh,
this is the one.
Right on the right. Okay.
Yeah,
Very good. Thanks.
Yeah.
Yeah, thank you. Thank you for those kind words. I think I'll start off with a story of the time I went to a cocktail party, and I knew no one except the hostess. And so naturally, when I walked in, I gravitated toward the group that the hostess was speaking to, and got involved in the conversation. Little by little, people broke away until I was left speaking with one woman, and she said, I have this joke, you see. It is so funny, it'll just kill you. It's about this doctor, you see. And I said, wait, I just want to avoid embarrassment. Just so you know, I happen to be a physician. And she said, oh, now don't you worry. I'll speak very slowly. Now, why would she say that? Maybe because she knew about these concepts and how frequently physicians can be fooled about the highly counterintuitive nature of screening, and cancer screening in particular. And I'm going to cover some of the things that make this such a highly counterintuitive field, to the point that many, many physicians who base their opinions about cancer screening on their own personal experience can be misled by what their own two eyes are trying to tell them and their clinical experience. We are taught from day one in medical school that the wise physician learns from their own experience, and that is certainly true. But this is a case where even a wise physician can be misled by their own experience, because even a harmful screening test can appear highly effective to the physician, and hence the controversy even amongst the health professions. So with that, a related quote is that in the field of cancer screening, it's particularly important to be able to sort out what is known versus what makes sense. A lot makes sense in the field of screening, but some of that is wrong, and we have to sort it out, and that's where scientists come in. Science, as many of you know, and I hope realize, is highly counterintuitive. If it weren't counterintuitive, then you wouldn't need scientists. We could all intuit our way through it and save a lot of money and time. Let me take you back to the dawn of enthusiasm for cancer screening on this slide. Now, this isn't the dawn of enthusiasm for medical screening. The dawn of medical screening actually probably goes back an additional quarter century to around 1900, when there was a keynote speech from the president of the American Medical Association, who talked about screening for all sorts of things, including propensity for criminal behavior, so that you could simply screen people for the potential for being criminals long before they ever committed a crime or even thought about committing a crime. But the dawn of enthusiasm for screening in cancer, I date back to this, where a Dr. Bloodgood from Johns Hopkins, highly reputable university, declared elimination of cancer was almost sure in its early stages, and went on to say that deaths from cancer would be practically eliminated if persons afflicted sought medical aid immediately on the discovery of a foreign body, of a foreign growth in any part of the body. Now, as you can probably see, at least those close to the screen, this was reported in the New York Times, the newspaper of record, again, reputable, and it was reported in the summer of 1924. And so now, well over 3/4 of a century have gone by, and we can look back and see how close to the mark Dr. Bloodgood was, and he was basing this statement on his own experience. And we know that cancer was and is, and for some time, looks like it is likely to be one of the most fearsome diseases that afflict us and the world, and if not the most fearsome disease in the United States. How could his own experience have misled him so badly? By the end of this talk, I hope you understand what the study biases and observational biases were that drove Dr. Bloodgood to such incorrect conclusions. Now, that was the most crude screening tests you can think of. Careful history, careful physical examination. Although not more crude than some of the highly recommended tests that you'll see in the newspapers, like total skin exam. We're still stuck with total skin exam, which is nothing more than be aware of your body, look for growths and so forth, and draw them to the attention of the doctor. Again, we are led often in our messages to the same conclusions, right or wrong, as Dr. Bloodgood, and I'm going to show you why he was off the mark. We've even boiled down screening into oversimplified messages, public health messages, and it doesn't get any simpler than this. Prostate cancer awareness stamp that you can pay money for and get these stamps, additional money, and the message there is annual checkups and tests. There's nothing about research. It's just sign a check and take simple tests, and that is probably oversimplified. Each year, the Washington Post runs this contest. What is the shortest verbiage in which the most inaccuracy has been packed over the past year in the newspaper? And a couple of years ago, the one that won was, "You've done a hell of a job, Brownie." But that has more words in it than this, which can be equally misleading. This is total lack of nuance, and that's the problem with the field of messaging for cancer screening, and to an extent, medical screening. This is a particularly egregious one that the American Cancer Society had out there. Ultimately, they caught some heat, and they took down the ad. But basically, it says, in essence, if you haven't had a mammogram, then you're crazy. There's something wrong upstairs, and you need something more than your breasts examined. And I think we've learned that things are a lot more complicated than that, and we shouldn't overemphasize the benefits without talking about some of the downsides and the nuance of cancer screening and how to refine it. Because by the end, I'm going to talk about research directions. The goal is not to do away with screening. As a matter of fact, we're not going to do away with it even if we wanted to. There's so much enthusiasm for screening, but we have to maximize any benefits that exist, if they exist. We have to find out if they exist, and minimize the harms, because the harms always exist, as I will show you. This is an element of fear-mongering. This is basically encouraging very young girls, teenagers, and preteens to be worried about thyroid cancer, as though thyroid cancer should be a bigger concern than the cute boy that sits in the classroom or doing homework or what I'm going to do for the weekend. This is truly oversimplified, because the harms of screening all young teenagers for cancers probably outweigh the benefits given the rarity of these diseases, but there's the messaging out there boiling down to sound bites. So the rest of the talk, I want to go through the public health aspects, because cancer screening, although it is performed in a clinical situation, often one-on-one, health professional and patient, it's really a public health intervention, because the target audience isn't single patients. The target audience is the entire public, usually of healthy people. Leon Gordis, who was a very famous epidemiologist from Hopkins, again, chaired the panel, the NIH Consensus Conference in 1997 on mammography in young women, women ages 40 to 49. And at the end of 3 days, actually months and months of sorting through the systematic evidence reviews, and then listening to speakers give their different points of view and updated evidence, the panel decided that it could not make an across-the-board recommendation in favor of mammography for all women in their 40s. Rather, it was a personal decision. They ought to know of the potential benefits. They ought to know about the harms of routine screening. And then physicians and health professionals should not impose their own opinion on patients. They should work through the pros and cons with them. But their conclusions met with a severe reaction. You're probably aware that the Congress convened and had a 98-0 vote to overturn the conclusions of the panel. A famous senator said that he was going to hold up the budget discussions for the NIH, for the entire NIH, until the National Cancer Institute considered and presumably overturned the results of the conclusions of the panel. And so there was and it was the first time I've ever heard of a 98-0 vote on an issue that is as complex as that, but there you go. But there was severe reaction in the audience, including violence, people pushing each other, and declarations that the panel was actually committing homicide. They were committing tens or hundreds of thousands of women to death with their conclusion. And he was taken aback by these reactions and wondered why so much violence, why so much resistance. And he came to the conclusion, which he conceptualized on this slide, that people were operating on 3 different levels in the audience before his eyes. The first level was, we're asking the question, what do you want, what would you do for yourself, or what would you recommend to loved ones? And there, of course, you don't need hard and fast evidence. You're judging based on your own personal convictions or fears, or whether your father died of prostate cancer and you're most fearful of prostate cancer, or whether your father died of heart failure and spent a year or 2 confined to bed and unable to even breathe easily, or might have died of a stroke and hadn't been able to feed himself or to speak or to walk. And so you have personal experience that guides what you most want to avoid. The advantage is, whatever your decision is, if it happens to incur net harm, it influences very few people. Level 2 is what a health professional is dealing with one-on-one, and that is, what would I recommend to my patient or client? Here, hopefully, you're dealing with a physician who is at least has some familiarity with the evidence, but we all have to admit that as physicians, we look to personal experience, as Dr. Bloodgood did, and sometimes personal experience can be very misleading. But at least it only affects scores of people, hundreds of people over any given physician's career. But then at level 3, you are dealing with what you would recommend to the entire nation and sometimes to the entire world. Here you're dealing with recommendations to hundreds of thousands, many hundreds of thousands, sometimes many millions of people. And here the stakes are very high, as we'll get into as we talk about some of the national experiments that have been taken that have been undertaken in the area of cancer screening. So here, if you make the wrong recommendation, you incur lots and lots of harm, and this is why the level of evidence you hope would be absolutely the very strongest, and this is why panels such as the Institute of Medicine strongly recommend that there be a systematic evidence review with a formal analytic framework rather than simply depend on experts or specialists who deal only with the numerator, not the denominator. This is a public health intervention, and it deals with the denominator. Sometimes we say medicine, to the extent that it is a science of the numerator, whereas public health is a science of the denominator. And sometimes there's a great divide between people who devote themselves to the numerator and those that devote themselves to the denominator. As a matter of fact, there's a great divide between advocacy groups that are disease-specific. They're in the numerator. Many times they realize they have popped out of the denominator and are the numerator, and they have a different perspective over what recommendations should be given to the denominator based on their own personal experience. Where general advocacy groups, like the National Women's Health Organization, are a denominator. They know that you have to really weigh a lot of the pros and cons because it is a bit like the lottery. There are very few winners in the lottery. There are a lot of losers, if you want to say paying out money is being a loser, but that's a loser. And as a matter of fact, in the lottery, mathematicians tell us that the only reason that lotteries succeed is that there are more costs than there are benefits. That's why states run lotteries, because they know they're going to pay out less than they get in terms of the cost. But in the area of cancer screening, it's not just $1 here or $5 or $10 here. It's actually, when I talk about costs, I want you to think of human costs, major surgery, exposure to proven human carcinogens. That's what is used to treat cancers. Radiation, proven carcinogen. And so there are downsides. The costs there in this lottery are a little higher in stakes. So I'll just go through the core issues in screening and prevention. And that is, it's difficult to make healthy people better off than they already are. most healthy people don't need an intervention. And yet, it turns out that it's not hard at all to make healthy people worse off than they already are. Because if they were never destined to pop into the numerator, but you expose them to the same costs that you're exposing everybody in the denominator, you've made them worse off. And there are a variety of ways that you can make people worse off that we'll get into. So therefore, strong evidence of benefit is important when putting large numbers of those people in harm's way, and those are the target population for screening, not the people who ultimately you know are going to have the disease. So for that reason, there are formal analytic frameworks that I alluded to, and this is one that is used by the U.S. Preventive Services Task Force, sometimes called the Task Force in the Agency for Healthcare Research and Quality. So these analytic frameworks are designed to make sure that we avoid our own heuristics and own mental shortcuts. The hallmark of any subspecialty is, of course, its language. You know, they develop their own code language, but also the mental shortcuts that they are trained to take. And this is true. Surgeons have their own mental shortcuts, and radiation therapists have their mental shortcuts, and so do physicians and medical oncologists. A shortcut that is probably not the right shortcut, but they all have a shortcut, is that a surgeon will tend to think that cancer is always localized and then very, very slowly progresses to the point that it escapes the organ and on and on. Whereas a medical oncologist probably also incorrectly always tends to think that cancer is a systemic disease, period. The truth is probably somewhere in between, and that's why we combine our therapy. But those are shortcuts that each subspecialist takes as they move through their day. They're helpful because you got to go to sleep at night, and you can't obsess over every decision, but sometimes they can be harmful, and this is one area where they can. On the left side of the slide is the healthy population, and on the right side is what the goal is. That is improving actual health outcomes. Health outcomes are not stage of disease. They are not tumor shrinkage. They are not ability to do surgery on more people. They are actually how the patient feels or functions, dead or alive, quality of life, and of course, did they suffer from cancer or not. And the most direct and efficient way to learn whether a screening test works, achieves those goals, is the direct pathway at the top of the slide. And the most efficient way is a randomized controlled trial. Short of that, there are too many confounding factors that distinguish people who get screened from those who don't get screened, or tumors that are screen detected compared to symptomatic tumors. And sometimes it is the fastest way of getting it. And if you don't do a randomized trial early on for a screening test, sometimes you can wind up behind the 8 ball because people make up their minds by the time the screening test is launched. But all the intermediate endpoints are intermediate outcomes because they're intermediate, not the ultimate goal. And then the testing and subsequent treatment have adverse outcomes, and we can't lose sight of them. If we only focus on whether there's benefit or not, then sometimes you say it's just you can conclude it's only money, and we're a wealthy nation, and we can afford to do things that don't work at all, even if they don't work. But that's never the decision. All medical interventions, including cancer screening, have harms, and they have to be kept in mind. And then finally, more recently, we are learning, even as the world's wealthiest nation, that we can't afford everything. The healthcare dollar is not, to our disappointment, infinitely elastic. So we can diminish the health of the population if we take resources from things that work very well and divert them to things that work very little or even not at all, and worst of all, that actually have a net harm. And in some cases, we are actually probably doing that in cancer screening, and I will get into that. But at some point, we have to learn. Now nations that have national health care systems know very well that the two questions, does it work, and should we do it, are two separate questions. In the United States, we traditionally have had the luxury of assuming that those two questions are one and the same, that if it works at all, then of course we do it. But we're learning that even that isn't going to hold up for very much longer. Whole states are going bankrupt because of medical care costs. So what fooled Dr. Bloodgood? One, the three important biases to keep in mind are selection bias, lead time bias, and length biased sampling, or shorthand is length bias. Selection bias occurs because not everyone who could be screened is screened. And the ones who decide to be screened tend to be fundamentally different and healthier from the ones who aren't screened. People who come in for screening, number one, are generally wealthier. They are generally insured, and so they have access into the healthcare system that others may not. They are generally very health conscious, and so they're searching the internet every 20 or 30 minutes to see if something else popped up on the internet that can make them healthier. Should they be eating more olives this week, drinking less coffee this week, or whatever it happens to be. And so these are people that are going to be healthy irrespective of whether or not they actually get screened. These are people who drive Volvos because they don't want to die in a car crash, and they're wealthy enough to afford Volvos, and they don't drive speed around in Corvette Stingrays and so forth. And so this is going to be a healthy population. They take multivitamins, they exercise, they on and on and on. And so whether or not they get screened, they're going to have lower risks of a whole bunch of chronic diseases, including cancer. We had the opportunity to look at that healthy volunteer effect, or selection bias, in a very large screening trial, the PLCO, for prostate, lung, colorectal, and ovarian cancer, which was conducted through the National Cancer Institute at 10 screening sites around the country, 155,000 people in the trial, half men, half women, screening for those 4 diseases. And we looked at the people the characteristics, baseline characteristics of the people who were interested enough in screening, health conscious enough, to sign up for the trial, randomized trial to be screened or not be screened. And so and we compared it to the National Health Interview Survey, HIS, which is the general population database. And we found out that the people who signed up for the trial had a far lower prevalence of smoking. Smoking was one of the biggest drivers of almost all the chronic diseases out there. Regular physical activity, they exercised a lot more. They were more educated than the general public. And they had less comorbidity than the general public. So you would expect, so you can't compare screening in this population to not screening in the general public because there are too many powerful confounders that would make you think that screening works even if it doesn't. And in point of fact, if you look at the standardized mortality ratio in the PLCO participants, and the standard mortality ratio is nothing more than the ratio of the deaths observed from each of these causes to the deaths expected out in the general population. And you see highly statistically significant. Every cause of death was lower in the people who entered the trial, even though there was no intervention for any of those other diseases besides the PLCO cancers. And the one that I find the most amusing is that if you signed up for the PLCO, you had a statistically significant 35% reduced risk of dying of injuries or poisoning. And I can assure you, we had no brochures about how to avoid injuries or poisoning. This is just a group that was less subject to totally unrelated causes of death. Lead time bias occurs because any screening test will advance the date of diagnosis. If it doesn't do that, we don't even call it a screening test. And so there's a guaranteed survival time built in for screen-detected cancers. And so again, you cannot compare the survival. This is what probably fooled Dr. Bloodgood the most, because he was used to his patients dying very quickly after a diagnosis of cancer. And now when he started careful physical examinations, their survival time, that is survival from the day of diagnosis, was much, much longer, even if they happened to die, as depicted on this slide, on the same day of the same cause. And he would never have been able to notice that because he was only looking at and gathering his experience from that numerator, which can be very misleading. Length bias sampling also fooled Dr. Bloodgood. It turns out that screening tests are far better at picking up the slowest growing cancers than they are at picking up the fast growing cancers. Why? That's on this slide. Almost invariably. This is almost a geometric certainty. I have depicted a population, half very fast growing cancers, the very short arrows, at the top half of the slide, and the other half of the population, very slow-growing cancers, indolent cancers. And you can see that a screening test enriches the population of diagnosed patients for the long arrows. Why? Because there are more long arrows. The arrows are out there for a longer period of time. The patients are asymptomatic, or the people are asymptomatic. And so you pick up the slowest growing cancers. You fool yourself into thinking that the screening tests work when actually all it's done is brought a different underlying biology to your attention. The extreme form of both of those biases, especially length bias sampling, is called overdiagnosis. That is, there are many tumors that are so slow growing, they never would have come to medical attention at all, never would have caused any symptoms at all, had it not been for that screening test, which converted a healthy person from healthy to a patient and subjected them to many, many therapies. And this is relevant to Peter Pinto's talk because he's devoting his research to try to get at this issue. How do you determine amongst the people that are screen detected who's going to really benefit, who's got the tumor that requires treatment versus the tumor that doesn't require treatment? But overdiagnosis occurs because screening will detect the slowest growing cancers, the indolent cancers, and so you wind up curing people that didn't need to be cured in the first place. And as I say, the stakes are very high because the treatments are quite morbid. This often involves major surgery, and the harms are front-loaded. The benefits, this is the nature of prevention in general and certainly in screening, the harms are suffered often at the beginning of the course of the history because that's where you get most of your therapy. The benefits, if they occur, are delayed by 10 years, 15 years, sometimes 20 years or more. And remember, cancer is a disease of aging, with some exceptions. And there are exceptions, but nevertheless, once you reach a certain age, the risk of you dying of something else is just as great or greater from the something else than it is from the cancer. And so if you're never destined to die of the cancer, then, of course, you'd rather never be diagnosed. What are the requirements of overdiagnosis? You have to have a silent disease reservoir. We're learning more and more there is almost always a silent disease reservoir. The more we learn about the biology of cancer, the more we know that there is a reservoir of things that a pathologist is willing to call cancer, but don't act like we generally think about cancer. And then activities leading to its detection, particularly screening, but it doesn't have to be concerted screening. It doesn't have to be intentional screening. It could be the CT scan of the abdomen done for somebody that just complains of some abdominal pain or discomfort. And a CT scan can pick up all sorts of incidental findings that sometimes go by the name of incidentaloma, and a lot of incidentalomas are not malignant in nature, but they could look like a cancer. So getting back to the biology, the underlying biology that drives overdiagnosis, it's due to the heterogeneity of cancer prevention. This is oversimplifying cancer, but we sometimes say, with some justification, but this is definitely oversimplification, that cancer starts with one errant cell. You know, your cells are constantly diverging and on, accumulating mutations, and then suddenly one cell goes bad. That's the cancer. It has a more constant doubling time. It doesn't, the daughter cells don't die, don't go through apoptosis as frequently. And so the cancer grows and grows until ultimately it's large enough to cause symptoms, and then ultimately large enough to create the total body burden that is lethal. But in the meantime, along the x-axis is time. And cancer is a disease of aging. And so as you age, even if you have a cancer in you, you are prone to die of other causes. And so as my father used to emphasize to me, you're never going to get out of this world alive. And so something is going to get you. And so you have to keep in mind what it is that's most likely to get you. And so a fast-growing cancer, the cancer natural history is likely to cause your death before the other causes. A slower-growing cancer can still cause your death before the other causes. You'd like to intervene if you can, to the extent you can, and avert a death from cancer and have the patient to go on and die of other causes. But we're learning that there are very slow-growing cancers that grow so slowly they would never have caused medical problems. And then there are even cancers that are non-progressive or even regressive. There are cancers that spontaneously regress. Even tumors of infancy, like neuroblastoma, have been known to do that. Lymphomas can do it, and spontaneous regressions. And so we have to keep in mind that cancer doesn't always move completely in one direction with one disease. And that's overdiagnosis. And from what I've already said, cancer screening tests, by and large, are far better at picking up these than they are picking up these. They're worst at picking up these. Those are the ones we really would like to have a cancer screening test pick up fast enough to intervene. But unfortunately, we're stuck with most of our screening tests in missing those. What is the evidence at the population level? What does overdiagnosis look like at the population level? Well, it's a rapidly increasing incidence of tumor, more and more diagnoses, but no difference in chance of dying of that disease. So here's a classic with melanoma. And that is, it's one of the fastest rising cancers in terms of incidence in the United States. And that, by the way, tracks with the number of skin biopsies. There's an increasing propensity to do skin biopsies in the United States. And it is going up very rapidly. Almost all of the increase has been early stage disease, as you can see in the bluish line under the total incidence line. But in terms of late stage incidence, the real killers, there's been very, very little change. In terms of mortality, also very, very little change. Now, a perfect screening test will pull late stage cancers out of the future into the present, right? And so after enough time's gone by, you should see, with this rapid increase in incidence, late-stage cancer not just decrease a little bit, but go away with this much increase in incidence. And so whenever you see that it doesn't, you have to start thinking about overdiagnosis at the population level. And this is the largest human experiment, I think, that we've ever done, with the possible exception of giving all postmenopausal women in the United States hormonal therapy, and we got burned badly that way. But this is the experiment we decided to do on men instead of women, so we're an equal opportunity society. And here, without knowledge in hand that there was a net benefit to PSA screening, you can see what happened even with a simple screening test that isn't all that sensitive. We know it's not very specific, and Peter's going to talk about that, but it's not all that sensitive either. And we've dipped into a huge reservoir of silent tumors that look like prostate cancer, and you can see what has happened. And over that era, it's estimated that about 1.3 million men who had never been diagnosed with prostate cancer have been diagnosed as a result of screening efforts and early detection tools that are only, we have to say, are pretty crude. What's happened to mortality? The risk of dying went up, it went down. It's now down to a little bit lower than it was in 1973, but it's not far below what it was in 1973. Usually when you hear that, that screening has gone, mortality has gone way down, it's usually measured from that peak, obviously not measured from that lower baseline. But what has happened over the last half century or quarter century as a result of that? Well, as I already told you, survival has gone up dramatically with prostate cancer because we're picking up people who have more indolent disease. And the cure rate has gone up dramatically because, again, we're curing people that didn't need to be cured. So the trick is, and Peter will devote his whole talk to this, how do you distinguish the ones that really needed treatment? Now, some people look at that and say this is evidence enough that PSA screening works. As a matter of fact, I've seen a paper that reported a regression diagram. It plotted the density of urologists per 100,000 people in the population, and showed that mortality rates for prostate cancer went down the denser the population of urologists. And that was used as evidence that screening works because they said the number one thing that urologists like to participate in is screening, and so therefore screening must work. More urologists, more screening, lower prostate cancer. But there's another paper out there in the literature, which is a classic, that did the same thing for pairing storks in the greater Berlin metropolitan area. And it showed that fertility rates dropped as the number of pairing storks were dropped as well. And of course, in jest, they reported this and said, this shows that the stork theory, rather than sexual reproduction, it should be the dominant theory. that is taught in public schools. This is mammography. This is what mammography has done. In the upper part of that graph, you see the increased rate of screening with mammography. So it maxed out in the 80% range. And in the lower portion of that graph, you see early stage disease and late stage disease for breast cancer. You can see that the trends have been dominated by early stage disease, i.e. screen-detected disease, and very little decrease in late stage disease, about an 8% decrease in late stage disease. And this is only when early stage disease was all invasive. Ductal carcinoma in situ would make those curves look even worse. The non-invasive form, which screening is particularly good at picking up, and ductal carcinoma in situ, whose natural history we don't even really know, accounts for about 25% of mammographically detected breast cancers, so-called breast cancers. And so, again, the stakes are very high in terms of the balance of benefits and harms. And it turns out, by the way, that all of the increase in breast cancer is all of the decrease in late-stage breast cancer is restricted to regional breast cancer, stages 3, node positive for the most part. No decrease whatsoever, none, in metastatic disease, which is a little bit disappointing because enough years should have gone by that if you were pulling metastatic disease out of the future, we should have noticed it in the trends of metastatic disease. And it turns out that adjuvant therapy, which is not particularly good chemotherapy is not particularly good for metastatic disease. It's quite good for the intermediate zone of breast cancers. It's been shown in multiple randomized trials to decrease the risk of dying of breast cancer. And so even what we think is the magnitude of the benefit of mammography may not be quite what it was years ago, because all those trials, the randomized trials, were done in an era before adjuvant therapy was being used routinely. Now we know, and it turns out, this is an irony, the more effective your therapy is for a little bit later stage, the less you have to depend on screening to achieve the same results. So I've shown you prostate cancer, I've shown you breast cancer, and I've shown you melanoma. The same is true for kidney cancer. We don't screen for kidney cancer, but there's a lot of CT scans out there, and it picks up these small tumors that pathologists are willing to call cancer, but no change really, no substantive change in the risk of dying, and the same thing is true for thyroid cancer. Remember the little girl that was being, teenagers that are being encouraged to worry about thyroid cancer. So the current challenge with cancer screening is predicting which of those lesions that are detected by sensitive screening tests. Our focus has been on more and more sensitive screening tests. Everything seems to be on getting the most sensitive screening test, pick up the smallest tumor you possibly can. But the trick is, and Peter's devoting his career to that and will devote his entire talk to it, and I'm not going to get into the details therefore, but we need to distinguish those tumors that are screen detected that need treatment, and even better, that not only need treatment but benefit from treatment from those that don't need treatment in the first place. How do we do that? This is where the scientific community comes in. We need to distinguish screen-detected cancers from clinical cases. Too frequently, physicians don't even collect that information. We collect no information prospectively on how the tumors were diagnosed. The oncologists generally don't even care. What do they care? They care about stage 1 versus stage 2 versus stage 3 versus stage 4, because that's how they guide their therapy. But a screen-detected stage 2 may have a far different biology from a clinically detected stage 2 and so forth. And as a matter of fact, that's true. We've learned that from molecular fingerprinting and natural history when we have the opportunity. So we have to determine the molecular patterns of the two classes of tumor to try to distinguish them. We have to look at targets for primary prevention, because if you were developing primary prevention, you wanted to attack the real killer cancers. That is, you gain less from a chemopreventive intervention that only decreases the incidence of non-life-threatening cancers. You gain more when you have an intervention that goes after the symptomatic cancers or the life-threatening ones. And we also have to collect normal organ around the tumors. Cancer is not just a cellular disease. It is a tissue-based disease. As a matter of fact, many would say it is a host-based disease and a population-based social disease as well. At many, many levels, we have to understand what drives tumors. But at the molecular biological level, we have to understand not just the cells, but what's going on in the tissue around. So I have taken you across this entire, the analytic framework from left to right and showed you where Dr. Bloodgood had, was misled and why we use this analytic framework to avoid problem. But I haven't covered the adverse effects. And so I'm going to go down very quickly the consequences of screening. We all know this. I don't have to emphasize it to you. A good consequence of screening is reduced risk of death from targeted cancer compared to no screening. And the most efficient way to get at that with confidence is a randomized controlled trial, not observational studies, not personal observation that are subject to confounders. The other is reassurance. Of course, some healthy people feel they need to be reassured that they are healthy. They're worried, well. But it turns out that most screening tests are, don't offer any real useful information when you look at it mathematically to somebody who feels healthy, because the negative predictive value is very, very, very low. That is, if you have a 99% chance of not having cancer, a negative screening test will increase that chance, probability, somewhere between 99 to 100%, maybe as high as 99.2% or something like that, 99.5%. But that's not a whole lot of information for a particularly healthy person. Now, there are bad consequences, false reassurance. When you have cancer, when you actually do have cancer, ignore symptoms. False alarms, lots of false positive tests, and harms of the unnecessary workup. Harms of the test itself, bleeding, sepsis after biopsy, perforation of a viscus, infection, detection of, and there's a lot of sepsis that is apparently coming up more and more with these biopsies for prostate cancer. Detection of a lethal cancer without changing the outcome. Unfortunately, that's the case for most of lethal cancers, because we don't take the mortality rate of lethal cancers down to 0. In the lung cancer screening trial, where the reduction in lung cancer mortality rate was somewhere between 16 and 20% on a relative scale, leaving all the other cancers that were unfortunately still just as lethal, and screening didn't do anything. And then detection of non-lethal cancers and overdiagnosis and resulting overtreatment. So but another thing we have to learn is how best to communicate the complexities of cancer screening to the public. Post office stamps are not the way to do it. Posters in airports are not the way to do it. Sound bites on television are not the way to do it. It's more complicated than that. And this is the way we tried with the National Lung Screening Trial. We added up the benefits and the harms. The benefits are above. This is a positive trial. And it's actually 3 in 1,000. For every 1,000 people that are screened over 7 years, we estimate, our best estimate, that there are 3 fewer deaths from lung cancer. And actually 5 in 1,000 died fewer from all causes. But in exchange for that, these are the numbers of false positives, 223 out of that 1,000. These are the numbers of false positives that led to an invasive procedure, and 2 is the number out of that 1,000 that a major complication from that cascade of events. So we're trying to, the same thing for mammography. For every 1,000 women aged 50 and above, the benefit is somewhere between 0.3 and 3 women or so will avoid dying from breast cancer if they start screening in their 50s over the next decade. The harms are that more than half of them are going to have at least one false alarm. 70 to 100 are going to undergo a biopsy, and between 3 and 14 are going to be overdiagnosed. That is, their tumor never would have come to medical attention, and they're going to get the same full-court press therapy, anti-cancer therapy as well, which often involves lumpectomy, sometimes mastectomy, often involves radiation, and then chemotherapy and or hormone therapy. Are there lessons for the research community and health professional community? I'm going to leave you with this one last slide. The research community and the health professional community has to learn this lesson. You cannot shoot first and then start asking questions. Unfortunately, that is what happened to us with prostate cancer. As I said, the world's largest experiment, or at least the largest experiment in our own country, was launching this PSA screening messages, campaigns, and on and on and on. Whole societies built their messages on one thing, that is PSA screening. You saw the trends that resulted from that. We are still struggling to try to figure out if there is a benefit to screening. The 2 largest trials had every reported have come to divergent opinions. The one done in the United States in a principally screened population showed no benefit, all harm. The one done in Europe showed benefit, but also a lot of harm. So we're still struggling, but the problem with the trial in the United States was we had already made up our minds. We shot first, and there was a high contamination rate. People who were randomized not to be screened felt that they were randomized to the wrong arm, and so that probably blunted the statistical power to see a difference if there had been a difference, although we saw no hint of a difference. So that's the lessons to the health professions, and that, I think, is a segue to Peter's talk about how is the research community going to get us out of this bag that we have put ourselves in prostate cancer.
Okay, thank you very much. Well, we'll take a few minutes for some questions.
Gilbert Welch has an op-ed piece in the New York Times, I think, a few days ago, suggesting that the Affordable Care Act has biased medicine by reimbursement rates to more screening and less therapy. And isn't this still a consequence of the love affair with screening that is continuing to affect medical practice?
Yes, and he writes a lot about that. And as I said, the intuition is so strong, and the emphasis, as a matter of fact, there are quality indicators, not whether by which a physician is judged sometimes, not whether they had a full informed discussion with the patient and allowed them to make the choice, but whether or not the patient got sent for the screening test, or whether or not they gave the patient a prescription for the screening test. And in some ways, I think that has perverted the incentives in the health professional community, especially if I want to say I'm a strong proponent of the Affordable Care Act. I think that the more people that get covered for health care, it is a right, it is not a privilege. I think this is one way to cover more people. But it doesn't have any brakes on. Right now, it just has an accelerator, and that is get more people that were not able to get care into the healthcare system. But there still needs to be a way to somehow get wiser about our therapy. That's not rationing care. Well, we already ration care. We do it based on wealth or other things that we don't like to think about. But it's not really rationing. It is determining benefits and harms and deciding that we are going to make sure that every person or more people get the things that are proven and have a lot of benefit, and not to disincent physicians to do the simplest, the wrong thing. And so the point he makes, and that you are obviously making as well, is a crucial one as we face the new healthcare, I hope, healthcare system. So now we haven't had a national health system. We've had a national health situation that we're living with. But I hope that your implication is absolutely on target.
Other questions?
Yeah, this is kind of a discussion question. Do you think it should be good to introduce new profession like screenologist, something I'm just trying to invent it, so that person who could have a better informed kind of helping patient with a better informed decision regarding whether to do this screening or not? Because having a lot of this test kind of markers that currently exist, primary physician probably will not be in a good position.
Yeah, so you're referring to a phenomenon known as the crowding out phenomenon. That is, if you depend on the primary physician, you can't say, ask your doctor, because the doctor only has 15 minutes or whatever it is. And if they spend their time going through all this complexity, even for one decision, then they've used up all the time that mattered to the patient. That is, why did I decide to come here today? Is there something really bothering you, and can I intervene? And that's called the crowding out phenomenon. And so it's easier for a physician just check, 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 check. My internist does it all the time. And I've had arguments with physicians or discussions with physicians where I say, don't order that test. I don't want, and I know that he's gone to grand rounds at the local hospital recently, and he's learned that everybody gets a vitamin D level, or gosh knows what it is, or a PSA, where it's part of his routine screening test. And I say, I don't want it, please. I think that the benefits may not be outweighed by the harms, but you can't depend on private physicians. And Gil Welsh is I would say, screenologist, if you want to refer to him that way. But there has to be a better way to reach informed decision-making. It can't be do whatever you want. It can't be I would get screened if I were you. It can't be I saw a patient with late-stage pancreatic disease, and so therefore I screen all my patients, and on and on. There have to be other ways. It might be group lectures. It might be pamphlets that are more nuanced. It might be encouragements to go to NCI-related fact sheets, because I chair the NCI Screening and Prevention Editorial Board of the PDQ, and we try to do that. We don't say get a test. We don't say don't get a test. We never say that. We say these are what we know about the benefits and the magnitude of benefits. These are what we know about the harms and the magnitude of the harms. And this is what we know about the generalizability. That is, just because it works in an academic center, does it work out there in the general public? And we have to do it a different way than straight through one-on-one interactions. You're absolutely right.
Yeah, some of those people who are in the pro-screening camp tend to say that it's not the screening that's the problem. It's that next decision. If you've come up with a positive, and that's where we should have the education, and not as to whether we screen or not.
Well, we have to attack it that way, but I think they're incorrect, because that's not what we do. The evidence is on my side, and that is giving information. By the way, not all information is good. That's an argument that information can't be bad. Not all information is good, especially if it's misleading. We have gone to war because of information that we thought was reliable, and thousands, if not hundreds of thousands of people were killed because there was some misinformation there. So we always have overconfidence in the information and think we can think our way through it if we're only given information. But we're headed into this even worse. Whole genome, genome-wide screening is going to give us, I would say, data. And so there's data or information. There is knowledge, which is the next step. And information doesn't always breed knowledge, and wisdom, and knowledge doesn't always even breed wisdom. So I don't think we can assume that it's okay, there's no harm in getting the information, aside from the fact that sometimes getting the information itself is harmful. By the way, labeling is harmful. You convert somebody from healthy to a patient, that has implications for their employment. Employment rates go down, by the way, in cancer patients. Almost across the board, underemployment and unemployment. And currently, we get most of our health insurance and access to the healthcare system through employment. So if we're underemployed or unemployed, we may lose our access to healthcare or go into a different healthcare system that we don't want to be in. That's one thing. Labeling also hurts. There are actually accumulation of data that just the diagnosis itself, information, you have it, you don't need to be treated. Suicide rates spike. And so employment drops, suicide rates go up with some of these diseases, including prostate cancer, by the way, lasting for 6 months or a year. So it's not with it. Labeling itself can be harmful. And the other thing is the test itself can be harmful. The radiation accumulated over years has a harm. And also, as I mentioned, some of the tests are associated with perforation. Some of the tests lead to a biopsy of the prostate gland. You're going through the rectum in an era where people, for reasons we don't know for sure, maybe it's a lot of antibiotic exposure, are developing these real infections, superbugs, and with within 30 days, admission to intensive care units with rather nasty bacteria. We're in an arms race with microbes, right? They develop a defense, we develop a defense. Defense. But we're not as good at it as they are. They can do it in hours. It takes us often years or even a decade. And so even the information itself carries with it some harm. And I never like to forget that labeling itself hurts as well. Okay?
So it would seem intuitive, to use your word, that countries with a national health insurance can cross the bridge easier between having made a diagnosis for which there is effective therapy, but the cost of therapy is totally out of the reach of the vast majority of the people. I mean, in my field, if you vaccinated everybody with hepatitis B vaccine, if you gave all the Hep C patients the new protease inhibitors, you'd probably eliminate a huge proportion of primary cancer of the liver, which is a killer disease. But that's not going to happen because the costs of both, particularly the latter, are through the roof.
Yeah.
So in your thinking and these various panels and discussions, to what extent do you go into the issue of the costs that are involved when you make a diagnosis?
Yeah, so of course you know that there are rules in place where the U.S. federal government is not enabled to make some of those decisions. As a matter of fact, some regulations specifically prohibit agencies or departments from making decisions based on cost. And so we're sometimes limited in the decisions we can make in that respect. I don't know if we'll ever get there, but nowadays, for hepatitis C virus, the pill that just came out, which apparently cures hepatitis C, I mean, that's a breakthrough. That's a real breakthrough. $1,000 every time you swallow a pill. And so there are countries that are saying $1,000 every pill, and you got to take it for how long? Well, 2 months. Oh, well, who's going to pay for that? Well, we'll pay for the first, we'll pay 80%, you pay 20%. And so that gets to be a real problem, even in our own society where people can't afford it. But some societies know, we all know, Pap smears were a major breakthrough life-saving screening test. We were an advantage because you're looking right at the organ that gets the cancer. It's that big. You focus all your energy on that. You scrape the cancer right off of it because that's where the cancer is. You look at it right under a microscope. So everything is working in your favor. We still have a lot of overdiagnosis, but that was a true lifesaver for one of the most common killers of all women in the world. Why don't countries do that? Are they stupid? Well, there are many countries that look at the cascade of events and the things that are needed, the organizational aspects that need to be in place to do that, from the initial examiner to the pathologist who's skilled enough, or technician and then pathologist, to the gynecologist who can do the surgery, and the equipment that's needed to do it, and the follow-up and so forth, and say, there is no way in the world we could possibly do that. So what are their hope is either visual examination with acetic acid, where you take just a layperson who's trained to look at the cervix and stain it with acetic acid, and or you develop a vaccine, and that's why the vaccines, hopefully, would be a game changer. But that's why they pay us feds the big bucks, and that is to think of all the possible strategies and figure out which ones are going to achieve the end that you want in the most efficient way. And another game changer, by the way, we give vaccines, 3 vaccines to young girls in the United States and boys in the United States, but it costs a lot. It costs a lot of money, and a lot of countries can't possibly afford it. Here's a real game changer that we're talking about, and I'm excited to be involved in, and that is less than 3 doses. If you could get if you could prove that 1 dose was effective as 3 or as 2, that would be an amazing breakthrough. Think of the herd immunity you could achieve at 1/3 the cost. And so we always have to think about strategies. I think that Pap smears are not going to do it. HPV screening may be a stopgap measure, but in the distant future, maybe we'll have multivalent vaccines, 1 dose, and you're done. That would, yeah.
You don't make much money making a vaccine. Listen, thank you very, very much, Marion. I think we should move along.
Sure.
So our next speaker is Peter Pinto, who is a physician, and he's trained in urology, urological surgery, and he was a fellow, did his training at Johns Hopkins, and I heard just before this that he came to the NIH to do research and do clinical work with prostate cancer so as to eliminate the PSA. Well, we're going to hear more about this. So, Peter, thank you very much. And we're also grateful if you want to introduce your patient.
Yes, so first of all, I want to say thank you for this opportunity. We need 3 hours for this on multiple days.
This is like the story, how long can I talk? You can talk for 40 minutes and then we go home.
Well, because, it is just amazing, and because this is hard work. It plays with emotions. as physician scientists, we're designed to look at the, on the cellular level, what is happening. And we lose the forest. And we forget how important it is that what we're trying to do with best intentions can often cause harm. And so I give Barry a lot of credit. When I was in training looking for positions, sometimes looking at opportunities for a young clinician and physician scientist is where you have mentors and people around you. And so the papers I read about this question really started to formalize a thought that I don't give up on screening. And I think we're going to screen, but we need better tools and better devices and better opportunities to screen more effectively. And so you can take away from that past hour this, well, why did I have this done? For my patient who came today, Mr. Kanchis, who's going to speak shortly, I could always only wonder, why did I have this, allow Dr. Pinto to take care of me? Well, because we don't know for sure. And I always say, and I've said this before, I tell the patients this in the clinic, if I could clone you and then treat today and watch the other person go with observation, I may have well just given you the harms of treatment and never gave you benefit. But we'll never know today. In my office seeing that patient, we did the best we can. And that's the emotional factor that's hard to deal with. Separate that out. So my lecture today will focus on what we're doing here on the NIH community to try in some small way affect a more efficient screening method. And so, when Wynn gave me this opportunity to lecture, I wanted to make sure we still remembered some numbers. As you can see here on the slide, yes, truly overdiagnosed, and at the same time, not to repeat ourselves from the previous lecture, yet we don't improve a lot in the way of mortality, improving the mortality. And so yes, this recommendation came to urologists. I'm a urologic surgeon. Trust me, this hit, you know this, during our AUA meeting. Never forget this. It was in Atlanta, and we knew it was coming, and I had engaged in research years before this to try to show that there's better opportunities besides PSA. But this is what we were told, that not screening is bad, but the use of PSA. Now, after that came an article, a publication that said, well, if we were to randomize patients to operate or do nothing, and then follow them for, in this case, 12 years, how do we help them? That's called the PIVOT trial. This came soon after that. And at least in particular for what we call the overdiagnosed low-grade tumors, what we found is we really had not improved anything. Now, you can argue, and we'll definitely postpone that. You can give us 4 hours. How about that? 4 hours. So, good. Postpone. Close. On the edge. So what we can see here that, yes, 10,000 patients, 13,000 patients, 5,000 were eligible. Of course, almost all of them declined to be randomized to nothing or surgery. But there were 700 who did engage in this VA trial. And over a 12-year period, and again, why 12 years? But I'll get to that. We really didn't see an improvement in death from this cancer. But what we did see, and that speaks to Barry's points, is we did see the clear evidence of harm in those patients, in particular urinary incontinence, erectile dysfunction. And those patients had the harms up front, and then the benefit is unclear. Now, they argued, and this is, again, the criticisms of papers, underpowered, only 12 years, we know it's a slow-growing disease, let's see what happens in 20 years. We've heard this over and over again. But on the heels, on the hearing about PSA decline, not using PSA, then surgery, I've decided to end my talk short and summarize that we don't need to screen for prostate with use of prostate cancer. We don't need to, even when discovered it, treating it. And this could be the death of an entire medical specialty. So with that, my father gave me a call and says, jokingly, and my wife left it on the voicemail, and we kept the voicemail. I actually recorded it onto a device to keep it. He said to me, Peter, the room in our house, it's still available to you. You can come home whenever you want. We heard about PSA screening. We heard about surgery not being helpful. My father's a businessman. And you can come back and you can work for the business. And I said, Dad, no, we were ahead of this. I knew this was going to happen. And actually, I'm doing well at the NIH, and I'm going to stay on, but I won't come home just yet. And the reason why is that because DRE and PSA have failed us. For those in the audience who don't know this, PSA, it's a blood test that can suggest that there's cancer in that patient? Well, it just leads to a blind, random biopsy. You just take the organ, in this case prostate, and you just hit it a couple of times, in this case 12 times. And you often miss lethal tumors and detect insignificant cancers. In essence, I think it's the only solid tumor that I know of that is routinely diagnosed without imaging for the hope of hitting the tumor. You wouldn't do this for breast cancer, you wouldn't do this for colon cancer, you wouldn't do this for other tumors. We just heard about the success of Pap smears and the visualization of the cervix. And so these biopsy rates fall short, and well, if you know this, even if you do more, if you poke it 12 times or 100 times, you still won't find all the cancers, and you're never sure when you tell a patient, you know, did we miss your cancer or do you truly not have cancer? And this is getting beyond just the screening test, but once we have screened, what are we doing? And this dilemma really, one of these focuses is well, do I give the reassurance to my patient if he is in screening currently to forego future biopsies? Should we then not even screen? Or if we do, the tools I have today are failing my patients. And so that's why the collaboration here with many institutions, including Peter Troike for Barrett Turkbay and the imaging program, Brad Wood and his colleagues in radiology, and myself and my colleagues in medical oncology have come together and said, you know, can we bring some devices on this campus, make some devices that allow us to image tumors with imaging for prostate cancer? One could argue, for those in the room who have gone through this before, well, there is imaging. I'm told by my community urologist he uses ultrasound to see the tumors during the biopsy. In essence, it's not the case. More than half the time, those tumors that are believed to be cancer are not cancers. This really, what we call grayscale ultrasound, fails urologists and physicians. It just guides the needle into hitting the prostate and making sure you don't miss the prostate. High-resolution imaging of the prostate, where is it? Well, it's MRI. And yet, as I left my training and came here, I was told, well, these are the images of MRI. This is what we see. We can't see anything. You know, if you look at this, it's too bright in the foreground. It's dark in the background. It's not clear where anything is. This is old technology. What we see now today is more in-detailed visualization of the anatomical features of the prostate. What we have in our pockets, our cell phones, have enough computing power that would take my first desktop and look like it's a shame. And as we continue to advance, there may be opportunities here to improve how we detect these tumors. And the anatomy there has details that are currently not cancer-specific, but just anatomically specific, but we hope to glean from these images tumors. So what we have is not just a single MRI that you can get in the community. In the discussion prior to this meeting, we were discussing how even in the academic centers of excellence across this country, this imaging technique is hard to replicate. It performs well here because the team has been developing this and improving upon this for decades. But like the early days of other imaging tests, it will improve, it will go on into the community. It just takes time. So these multiple parameters, what the key is that it's not just one sequence. And for those scientists and clinicians, it's not just a T2 phase. It's actually, there are functional imaging parameters in MRI. We call that multi-parametric MRI. It's not a simple test. It's definitely not mammography where it's a simple X-ray test. This is a somewhat extensive 40-minute examination of the prostate. And I won't go into detail because time doesn't permit this, but I will just focus on a few of these functions. Diffusion-weighted imaging, it actually looks at the ability for cells to crowd and affect the motion of water. And what you can see here is, you know, in this case, a large tumor, but you can see it now on the T2 phase and what's called the diffusion-weighted phase. It's a confirmatory phase on MRI, another sequence that this could be a tumor. There's typical contrast enhancement, where neovascularity, newly formed vessels around tumors bring blood supply in quickly, and those can be areas of hyperintensity. And then actually a true functional imaging spectroscopy, where you can examine actually different levels, choline and citrate, to see if there's tissue that is cancerous or benign. Again, not the focus of this lecture today, but when you take all these parameters together, it actually performs very well. It actually can then examine through the prostate and pick out those areas of tumors that are based on size, of course, and aggressiveness, and I'll get to that in a few moments. But this is really groundbreaking technology that my mentors were correct. It did not exist 5, 10, 20 years ago at this specific level. And so we can actually then score, and our radiology colleagues can then give a level of suspicion. And there's a subjective component to this. This is not an automated system. This isn't an EKG machine that gets the EKG and gives you a reading. It does require a physician to interpret that. But we're working on technology here to semi-automate these reads. And in particular, especially in the NCI, they've purchased additional imaging tools. In this case, it's actually a hyperpolarizer for C13 pyruvate to look at the metabolic pathways of cancer, and that can be viewed in the patient in conjunction with MRI for anatomical detail and give us what we believe might be the opportunity to see the biological aggressiveness of tumors. And this is exciting work for which we're going to link to actually genomic profiling with a colleague of ours, Rul Shanayan in Michigan, and working together on this aspect to see if we can look at beyond just imaging, but the biology of the disease. And so when people hear about imaging for prostate cancer, how it may change how we detect or maybe screen it, you have to actually show that it works. And so a protocol here on this campus where patients who had diagnosis of cancer, who then came to me for surgery, but first were imaged with our MRI technique, were able to then go ahead and analyze slice by slice the prostate MRI and the surgical specimen. The specimen, the pathology being the gold standard. And there were reports of this from the past, and literature previously didn't have a nice correlative connection. So they couldn't determine if they were in the same slice, imaging and pathology. And as a result, they were unclear as to how well the MR performed. To solve that, and this is just the example of going from imaging here to the pathological specimen, but to solve this, to make sure that we were in the exact same orientation and slice, MR and pathology, for each individual, we created off the MR software a customized mold or a three-dimensional model of this prostate. And actually, it got so good that we could even ghost into it the suspected tumor location based on MRI. And then it allowed our pathologists to actually whole mount slice the prostate at the point where the MRI sees different slices of the organ. And so we forced pathology to actually cut it where we believe tumors were. And then we forced the pathologist to cut the prostate where we thought tumors were not to see if we missed them on MRI. And this really stringent criteria for kind of correlating allowed us to do two things. Allowed us to, at a high level of confidence, procure fresh tissue for profiling, which we're doing now. So our colleagues and our basic scientists and PhD colleagues have now really rapid RNA extracted quickly because we can procure in a confident manner. And then we're going to go ahead, as I mentioned before, and sequence out these tumors going forward and see if we can see some biological activities that's different among imaging. And this whole process then came together over hundreds of patients to say, well, can we then have confidence? Is there a positive predictive value in tumor detection throughout the whole MRI? And this came out a few years ago. And what this work said was that T2 alone performs well but not great, and we miss some tumors. But as we add sequences, we have confirmatory sequences, we have more of confidence. And clinicians ask me, well, I don't care about PPV, I want to know about the NPV. I want to be able to, as a clinician, send the patient to you or some program like yours who has a suspicion of cancer, and I want to rule out cancer. And again, it performs overall, it performs very well. And this basis started our philosophy of, well, if MRI may see tumors, how do we have a device that can actually sample that tumor? And actually, we built one on this campus. And this was through a CRADA with Philips Corporation. And this is really, could not have, I've said before, it could not have been done anywhere else. We shared patients. We were not held to reimbursement issues. Our salary wasn't tied to seeing a patient without having it by our colleagues. So, you know, Drs. Choyke and Wood and myself, being FTEs here, just went ahead and had the same patient. We shared them, and we created with our engineering colleagues, pathology included, a device that could go ahead and sample what the MR believed was a tumor. This was the early days in 2007. And again, at this point, we couldn't see any of the trees. We were just focused on this one device. Not really sure if it was going to help or it hurt, but we just wanted to sample those tumors specifically in those MR areas of hotspots. Large machinery, definitely not community-based, definitely not office-based, definitely not physician-friendly. We had engineers that were sitting behind here real-time patients were on this table. Of course, the current platform today, almost 7 years later, is a more slimmed down version that may have portability to the community. We hope very soon. We use an electromagnetic tracking system to actually guide needles into what the MR said was positive. Remember, the MRI is a magnet. Anything ferrous is not allowed within the Gaussian line of the magnet. Yes, there are non-ferrous biopsy techniques that can be incorporated inside the MR, but the MR is a closed system. It's very difficult to manipulate any instruments in that system. So what we thought was, if the MRI sees a tumor, well then, and the biopsy technique is comfortable in the office setting on the typical ultrasound machine, fuse images together, bring the MRI out of the gantry, put it onto the machine in the office setting. This EM tracker made it possible. Of course, we did preclinical work, and we have the credit of the MRSP, at this time COTP and Howard U students present. Many of these students have now gone to their own programs. And in doing so, what you're seeing now is actually a real-time ultrasound image of a prostate, what they would use for blind biopsies, where the MRI is being ghosted onto it. The contours of both organs are being aligned. This is the software created by our engineers, and our clinical team helped refine the use of this to allow us to then to create the MRI interest, the tumor interest spots onto ultrasound. And in doing so, they actually move in concert. This is the latest version. This MRI is a static image acquired possibly weeks or months ago. And this ultrasound image is real time with the probe in the patient. And the MRI is moving with ultrasound. And when the area of suspicion is identified, in this case, it's called a target. You want to sample in that one spot, we can go ahead and localize it and pass a needle into the area. That spot was right there. Many of the harms we hear about biopsy, sepsis, bleeding, occur quite often because we perform many biopsies. If you don't know where the tumor is, you have to perform 6 or 12 or 18, in some cases over 20 or 30 biopsies per session. I couldn't imagine doing that for other organs, breast, for example, or kidney. If you can see the tumor, maybe we can limit the number of biopsies. It's ongoing work on the campus here. In essence, when it's working all together perfectly, you have this MRI with a very bright, in this case, healthy-looking prostate, and then this little dark spot that's poking into this bright area of peripheral zone. We overlaid a blue and red dot to make this more visible to the person doing the biopsy, and then we can direct the needle to that part. In essence, we can diagnose that tumor. And what I'm going to allude to in the next couple of slides is if we think we are over-treating this tumor, we have a large cohort of patients where we actually give confidence to them that surveillance or no treatment is the best option. And we can then forego future biopsies if we can see the tumor, we know where it is, and we know future imaging is not going to go ahead and see a progression of that tumor. And as many of the times, it doesn't happen, it doesn't progress. In cases like this was just a little focus of cancer. He had prior negative biopsies. One could imagine that the physician, well-intended, trying to sample this, did a random biopsy and may have put one needle here and one needle there. And it was in between his biopsy samples. As a result, he had more confidence in this patient offering either active surveillance or treatment or other options. And some of the publications that came from this were heavily criticized initially, but over time, as we amassed more patients in our series, were accepted. This one actually got onto the cover of our journal at this time. What this said was, if we have an MRI that can detect cancer, and we have a level of suspicion that's high, meaning that the radiologist feels this is an aggressive tumor, a biologically active tumor, and may potentially be one of those lethal cancers. This imaging and the biopsy techniques, this dark gray, finds that more often than a random biopsy was. It's intuitive, it makes sense, but until we have the data to support this, what makes sense isn't always correct. In addition, as I mentioned before, we can actually record locations and map these tumor locations, and therefore give more confidence not to treat these tumors. We can follow them over a series of time and not require biopsies to follow them also. And then the clinicians who came to us and said, I would like help. I want to help me stop biopsying my patients. Can we, once and for all, if I'm buying it, if I'm invested in PSA, and many urologists are, and I see the PSA continuing to rise, I know it's not cancer specific, and I'm repeating my biopsy year after year, Can this imaging stop me from doing that? Give me confidence and reassurance I'm not hurting my patients. And again, I do believe that many physicians are well-intended when they embark on PSA screening. It's a hard emotion to break away from. And yes, what we did, we analyzed the data from our last, I think in this series, 5 years of data. And what these two graphs show are this. If a patient came to us after his physician did multiple negative biopsies, so say 2 sessions, say over 2 years, or 3 years of biopsy, or more, it still performed well. We're able to detect cancer if hidden, if in a location that was missed with a traditional random biopsy. And more importantly, when the MRI again said, biologically, this is a tumor that's aggressive versus this is a tumor that's not aggressive, it worked. It worked well. And in many cases, these highly suspicious tumors were discovered. But I would argue that this slide is probably the most important one. Because if we know that we are overdiagnosing, and in particular overtreating low-grade cancers, well, at least we have to believe that the more aggressive, biologically active, high-grade cancers, in this case, Gleason pattern. What Gleason was a pathologist who was able to look at histological specimens and give a pattern to more aggressive biology than less aggressive. Gleason 6 is not very aggressive, and in some circles of the academic world, being considered to move back into atypia. And Gleason 8, 9s, and 10s are considered high-grade or lethal cancers. The question was, does the MRI miss the high-grade cancers? And so in these situations here, where there were 21 high-grade cancers, a patient came in for a biopsy. The MRI said this is an aggressive tumor. We blinded one clinician, and he did a standard 12-core random blind biopsy. And then the patient in the same setting, we turned on the MRI guidance, and we put a needle into what we thought was the cancer. In those patients, more than half the time, about 50% of the time, even for large high-grade cancers, the random biopsy missed it. And our patient today that actually was his story. And in cases where we had the MRI technology, we actually were 21 out of 21. We were 100% in detecting those tumors. And these are the ones that we believe we do want to detect. So applications for physicians. Not just screening, but what about surveillance? We know that we overtreat. I think the physician, and I think also the patient, feels more comfortable if there's a modality to interrogate the prostate with MR imaging and then rule out these high-grade cancers. I hope and believe that we'll have a larger accrual into active surveillance. We have many, many younger patients coming to us today who say, if I have reassurances the tumor biology is not going to be aggressive, I'll engage in that surveillance. And in doing so, we looked at patients who met criteria for active surveillance, and then actually were imaged here and biopsied. And sure enough, almost, I would say probably about, somewhere between 40% of those patients had a higher grade or larger tumor volume than first suspected, and we were able to use imaging to guide our needle to the spot. In doing so, they may have been disadvantaged by continuing to be on active surveillance. We're not sure, of course, but they may have been. We'll see. And I'll end very briefly with treatment options. I'll give an example, and this is an individual who is 60 years of age at the time he came to us, 5% of one core Gleason 6. He could have easily been on surveillance, low-grade, low-volume cancer. Imaging found this. People ask me when I give this lecture, well, how could this have been missed? Well, needles that pass through the prostate, as Dr. Kramer mentioned, come transrectally, and they only go as far as probably the urethra, and usually undersample the anterior part of the prostate. Even now that we know there's more anterior tumors than we thought, putting needles in there blindly can still miss it. Well, this actually had the Gleason 8 cancer, 100% of the cores from that area. So now the question is at 60 years of age, Gleason 8 cancer, do we go ahead and offer him treatment or not? It's not clear, but we did. Cases like this, where there's 63-year-old individuals, we want to, again, find out the aggressive cancers, prior negative biopsies, anterior located tumors, again, a high-grade tumor. And this young man over here, who's 68, and yet healthy, very active in his lifestyle, had 2 anniversaries, he told me. His wedding anniversary, and his anniversary for his biopsy in his physician's office. And he knew those dates on his calendar. He kept it consistent. And then on the 7th year, they actually put him asleep in anesthesia and took out 36 cores from his prostate. And sure enough, that tumor right there was the area that was missed. And, you know, for years, we couldn't even see these tumors. I mean, mammography's been around for a while, but for prostate cancer, it was truly just a blood test and then jumping to a random biopsy. So, you know, it's a whole new world now to see how we can improve on whether we even need to screen, how we screen. If we do use this technology, can we change how we treat, how we can give drugs, follow these tumors, we can give a medication, repeat sampling of the tumor, change for the biology. Of course, this was a Gleason 9 cancer in this case. And finally, this young man here had a Gleason 6 cancer, 5% of one core, and he was adamant he wanted treatment, but was not clear of the treatment options. He was trying to discuss the harms and benefits of each of the treatment options. At a volume that was this low, with the cancer biology of this low grade, again, based on a random 12-core biopsy, he was able to offer, consider active surveillance, surgery that could release and save both nerves, or putting in seeds, brachytherapy seeds, which is a very, sometimes it's called a low-grade radiation. And the MRI that was performed to make sure there were no other tumors found this large dark spot among his prostate. This tumor was biopsied, of course, came back of a high-grade cancer. And now his options have changed. The data that was collected has changed the treatment choices for this individual. No longer low grade, no longer 5%, no longer low volume. These options are now gone. We actually know the true biology of his cancer and the true tumor location and volume. If he has surveillance, one could argue at 57 years of age, we'd be hard-pressed to find a patient who would choose surveillance in this case. Maybe he will not die of this cancer at 57, Gleason 8. We don't know that today. So surveillance was not an option for him. If he had surgery, that MRI hinted that the tumor broke out of the prostate. The MRI says possibly it's in the nerve that we would try to spare to maintain quality of life, reduce harms. So would you take out that nerve on that side? We would. And if he has radiation, seeds are ineffective, the biology is too aggressive. There's randomized data from the Ebola trial to suggest that you get radiation plus systemic therapy. In that sense, that person went ahead to surgery, and that organ-confined cancer was found to be extracapsular spread, and that treatment option, we believe, was correct, but we'll see long-term. So in summary, recent advances in prostate imaging and biopsy devices actually built on this campus may, for the first time, hint towards an opportunity to screen effectively. I'm always told, well, Peter, MRI misses so many of these low-grade, low-volume tumors. That's a good thing. It may disregard those tumors and detect only ones that are aggressively, potentially lethal. But there is so much work to be done. We have to figure out not just anecdotally how this works, but on a larger scale, and can we export this technology to the community, academically, and into the settings beyond. Many of my team here, my collaborators, this was one of the NIH Directors Award we received, I think 2 years ago, are up on this slide. Of course, only the clinicians in the white coat. I didn't know any better. Got my suit at home. And of course, I would not be here without the mentorship of Marcy Linehan, who recruited me from Hopkins at the time when I wasn't sure what to do with my career. It gave me mentorship and gave me the opportunity to be in what really is a very special place on this campus. And with that, I would like to introduce, if that's okay, a very special person, Mr. Canchis here, and let him say a few words about his story. You want to do this? You want to? All right. So here, well, how about this? I'll let him go. He's got the podium. He can tell his story. Go ahead.
Good afternoon. My name is Canchis. I want to say two things that I've been lucky twice. First, that I was elected by Dr. Pinto and his team to be treated, to be part of the program. And I am pretty sure that if I were not that lucky, maybe today I wouldn't be standing here, because my cancer was very aggressive. And secondly, I wouldn't be standing in front of such a prominent audience of scientists and prominent physicians. So thank you very much for such an opportunity.
Oh, not just yet. We'll keep you here for a couple more seconds, because I wanted you to explain to the audience a little bit what happened. He had entered into screening, and was it? I don't even know if you clearly understood what that was. I think it was what Barry had pointed out. I think you just got the box checked. I'm not even sure if you were asking for be screened for prostate cancer, or you went to your doctor. Which was it?
Well, it was very simple. I never thought I was ill. I led a very active life. I played serious tennis and still playing today. I thought I was healthy. My daughter is a medical professional, and she once said that, Dad, you have to check your PSA test for just because of your age. And I went to see my local physician, and he did blood test, and he said, you have a problem because your PSA level is high. I was fortunate because he said, but I don't know what is your situation, but fortunately, I live in the Washington metropolitan area, and he said, I know Dr. Pinto and his team, they have a very advanced program, and I would ask maybe you could get tested because of what Dr. Pinto today presented. That's how it started. And as I am saying, I was very fortunate because my cancer case, as I was advised, I'm not medical professional, was aggressive. And today I don't know what would have happened to me. Maybe I would be still alive, but definitely not in such shape as I am today.
So his urologist was able to do a random biopsy and found, and this is the case actually, this is the case, those are your images, a single core, a single focus of low-grade, low-volume cancer. And you know, as part of the trials, we just investigated to see could we detect other tumors. And so one could argue that this type of low-grade, low-volume cancer, even at your age, is a disease of aging, and that it's probably, you were probably unlucky to have found it. What we're trying to do with our program here on this campus is to vet out those patients that have hidden tumors, which happened to be your one case. So the imaging that was performed found this anterior tumor, and that was the spot. That was the more aggressive biology. There was low-grade tumors elsewhere, and they probably are not the index tumors. And this is the one that had to be treated, and that's how it worked out.
And most importantly, I had no symptoms. I had no typical symptoms which doctors ask you. Do you have to get up at night to go to bathroom? No, never. Do you have any discomfort? No. I had absolutely no symptoms, to be honest with you, and it was a big shock for me. Anybody who went all this through could imagine what you could feel once you feel as if you are jailed or as if you are sentenced to something because you don't know what to do next. You practically, the rest of your life becomes meaningless overnight. So I'm not exaggerating anything. I'm simply sharing with you exactly what I went through. Today, by the way, I started forgetting about it. And 25 months passed only since my surgery here in this particular complex. So again, I consider myself very lucky. Well, I appreciate very much the opportunity to see you on the screen, and even being just observer, not specialist, I come to conclusion, this is my immediate reaction, that in life, everything is about resources and funding. I have an advanced degree in economy and financing, and my job is financing infrastructure, large-scale projects that I've been doing for 30 years. This is relevant to today's discussion, but at the same time, it's always about the cost and whether money is spent effectively or not. My view is that you cannot put the cost of a person's life. And at the end of the day, if the pilot program, which Dr. Pinto, I believe very effectively by this presentation performed, it can be expanded it would help to save a lot of lives, and maybe to save even money to reach the same result as you have presented before, to reach the same result with the lesser cost. That is my immediate reaction to, because I'm trained professional to count money and to see the best result for less capital investment. So this is, I apologize. So this is what is all about. I believe that at the end of the day, each technology has to be tested, but it has to be tested not only for effectiveness, but cost effectiveness as well.
And this is what people share on this campus, is to run the trials and see if it's effective clinically and also cost effective. I wanted to thank him also, because when you asked me to find the patient, it was challenging. We were scheduled during the snowstorm in January, and this young man here was coming back from overseas travel, and on short notice, Patricia was very helpful, your assistant. He came over here. So I want to thank him very much. Thank you.
Thank you. I'm not that young already.
Yeah. Thank you. That's our next step. So in these cases, we have not. No, this is pure imaging. I wanted to see at the time when other solid tumors had imaging, kidney cancer, brain tumors, breast cancer, pancreatic tumors, you can go on and on. I wanted to see if we could, as a specialty, bring imaging to prostate cancer. Peter Choiky's team, Brad Wood's team, they've done that. So the next phase is to go ahead and work with colleagues like Arul Shanai in Michigan to profile all these tumors and look for biological activities. Yes.
Do you keep all the material?
Yes, we do. So we have a protocol for which these patients are very appreciative. And so we have a large biorepository in our branch for which we have those opportunities, and they're matched to those areas. And again, it's the patients that do this. Without their help, this could not have been done. Right.
Peter,
yes.
Nice talk. I wanted to ask you about the screening technology for prostate cancer to begin with. I mean, I wasn't clear if you were saying that we shouldn't do PSAs or we should do them, but we should do a better job of interpreting that data, because PSA testing, my experience is that it can be a very valuable test if you follow it over time. And you don't necessarily get a biopsy right away, but if you have 3 years of, what's that?
Use the microphone so they can
If you have 3 years of PSA levels that seem to be, the slope
right.
is going up, and finally your primary care physician says, this has been going up for 2 or 3 years. It's not very high, but it might make some sense for you to get a biopsy.
So this is a very important question. Yeah. So I'll give you what we think about this. Actually, at the AUA meeting coming up in 2 weeks, a work from our lab, where one of our students just received Outstanding Poster Award. It's one of, I think, 10 posters to be outstanding. And what we analyzed was the PSA cutoff for which the imaging may be a filter. And so we didn't get rid of the PSA completely, but we said, okay, fine, if PSA is an entry point where the next step is a random biopsy, for which there are probably millions of biopsies performed unnecessarily in this country, can we create a filter and hold back all the necessary biopsies? And what we did over the past analysis, retrospective analysis over the past 5-year data points, was to find that at a certain PSA cutoff in trend, velocity, there is a point where the MRI can intervene successfully. But again, when I was speaking to Dr. Kramer about this, we have to figure out on a larger scale how we can do this and make sure that this is reproducible off this campus. But to your point, we're not giving up a PSA completely. I'm conflicted, though, because I am not so sure if we shouldn't abandon PSA completely and move on to something else, whether it's a different biomarker or, in this case, we're heavily invested in imaging. If we get to a point where, and this is another trial on this campus, where we're actually taking the cost down, so there'll be a point of cost. You went through this, a 45-minute scan with multiple parameters, and all the bells and whistles. is done from a research standpoint. If we can modify that to a 15-minute or 10-minute scan without IV contrast and other modalities, and then use that as an entry point, that may be something helpful. Again, all this stuff has to be worked out. It'll take years to do this, but it's worth the effort. It's worth the effort.
That's fine, but right now, the technology is such that while it's undergoing development,
Yes.
and it's only available in some places,
Yes.
does it not make sense to keep doing something like PSAs? And if you're going to replace it with something, what would that be that is as easy and uncomplicated for primary care physicians?
I don't know, but I'll tell you why. Because I believe in the data. If you've seen how mortality rates have not really been affected by our screening tools, and that's really two things. That's a rectal exam and the PSA test. Now, if this MRI or something else can blow it out of the water and we see mortality drop, I'm not saying it's going to happen, but I'm going to make an effort, and I'm going to help, Dr. Kramer is going to help me make sure that we do this correctly. But wouldn't that be fantastic? I mean, so what if we had that technology? What if it's a combination of imaging and a genomic profile? As I told my father, I'm staying on campus, getting some work done. We're going to try this. And I think there's a reason for it, because these lethal cancers, we've seen people that they come in at a very young age, anecdotally, with PSAs 1,000, 37 years of age. I operate on these patients. They have tumors throughout their pelvis. And, these young men probably have they're in the age before screening. So it's a different, we don't know. We're working hard on this. We're working hard on this.
I hope it's not personal, but do you have family history of this type of disease?
No, I don't. The only thing I want to say about my family, since this is the question, it is not related to me because your wife is not your relative. But my wife was, based on regular screening, diagnosed with colon cancer in 2005. And age, she was born in 1953. So she was diagnosed by Dr. Witten, who is known in the medical community, I believe. And based on the screening, she was rushed to Georgetown Hospital. And next day she was operated. And she had very little symptoms, because she was diagnosed or advised by doctors that about any other symptomatic discomfort other than colon cancer. She was operated and she survived till this day, 10 years. She is okay. Now, and based on the family experience and my wife's and we believe that we've been saved because of the screening. That if she were not screened for colon cancer, I believe that based on the severity of the case, it would be very, very grave consequences for her.
So so the question was, he's aware of what's called HIFU treatment for prostate cancer being used quite extensively overseas, but not really in the United States. And what HIFU is high intensity focused ultrasound. It's a new form of ablative technologies to destroy cancer, in this case applied to the prostate. And I was invited to go overseas at the Royal College of Surgeons at a forum to give my perspective on this. And I think that we don't fail in creating new devices to treat cancer. Behind that, there's 3 other new devices in development. The problem is, who to use these upon. And that's why, you know, trained as a physician, as a surgeon, my focus is actually the other side, is to filter out those who need treatment. In particular, what you're asking about, not FDA approved in the States yet, and you have to ask yourself why that's the case. So I think the data is still lacking on these long-term survivals. Now, the lead time bias and looking for mortality, overall disease improvement from cancer and also from the outcomes, it'll take a while. And so those technologies, I would resist adopting them until they're in clinical trials in the States first. And we're doing that now. We have a trial coming up here that will investigate that.
Yeah, up to now we've been talking about PSA as a screening tool at the initial stages before we know that the person has prostate cancer. How about your views? Is it a useful tool after somebody's had radiation or other cancer treatment?
So I always tell the patients that, you know, at least PSA may have failed us in finding your cancer, but it's been used effectively for post-treatment assessment. Now, for radiation, there are what we call bounce effects. Not being a radiation oncologist, I don't want to speak out of turn. And I don't know exactly how that's used to judge the efficacy of the treatment from radiation. But with surgical removal, with the exception of a few other sites that can make PSA, we have very sensitive assays to detect PSAs down to 0. And that, now remember, it's not detecting cancer. So if there are a few cells left behind that are benign in nature, you'll see a PSA rise. But for those cases where the PSA remains at a very low value, historically it was below 0.2, it gives confidence to the clinician that there's no return of the tumor, correct? Yep.
Okay, well, listen, on behalf of all of us, we want to thank you, sir.
Thank you very much.
And thank you very much, Peter. And thank you very much, Brian,
Sure.
for a very stimulating topic and discussion. A lot to think about. Thank you very much.